Hi, Adult Health 2. This is chapter 41. This is number 2 of 4 PowerPoints. This is just about the anterior pituitary and the associated disorders. So this is a really short little PowerPoint here. Here is our objectives. So disorder overview. So the pituitary gland controls a lot of functions. It includes growth. Okay, that is probably like the biggest one. So includes growth. It does play a role in fluid balance, metabolism, sexual development. That's huge related to the pituitary and pigmentation. Okay. So disorders related to the function of the anterior pituitary may be caused by an increase or decrease in the secretion of hormones from the hypothalamus or the anterior pituitary gland itself. Remember, the hypothalamus matters because the hormones released from the hypothalamus stimulate the anterior pituitary. So don't forget that whole cascade thing related to hormone release. Primary disorders are related to alterations in function of endocrine glands. So this could be like the adrenal cortex or the thyroid. Secondary disorders are related to alterations in hormone secretion from the anterior pituitary gland. And then tertiary disorders are related to hormone secretions related to the hypothalamus. So there's 3 different ways basically you can end up with these disorders. So patients may present with disorders related to one specific hormone, or in very rare cases, they may present with panhypopituitarism. Remember, pan kind of means all, pan. We talked about that with pancytopenia, right? Where all the cells are low. Okay, so panhypopituitarism means that a bunch of these hormones are low or having problems. So this disorder, panhypopituitarism, involves hyposecretion of all hormones from the hypothalamus and has dramatic effects on normal function. Hormones secreted by the anterior pituitary are controlled by hormones secreted by the hypothalamus. And you can look at table 41.1 for that, okay? Shows the cascade. So hormones released from the posterior pituitary are synthesized in the hypothalamus, but stored and released from the posterior pituitary. So the anterior lobe of the pituitary secretes several major hormones. Adrenocorticotropic hormone, ACTH, that is involved in the synthesis of corticosteroids. We've talked about ACTH before. Also growth hormone. Okay, and growth hormone stimulates growth through carb, protein, and fat metabolism. So super, super important. Then we have follicle stimulating hormone, FSH. That is for the females, maturation of the ovaries, and it does play a role in spermatogenesis in male individuals. So birth of the sperm basically, right? Then we have luteinizing hormone, or LH. This is involved in ovulation and testosterone production in males. Prolactin stimulates the mammary glands. Thyroid stimulating hormone, TSH, we talked about that in the first PowerPoint. TSH controls secretion of T4 and T3, okay, which are the thyroid hormones. And ADH controls water retention by the kidneys. Oxytocin is another one related to this, plays a major role in circadian homeostasis, so sleeping, and release of breast milk and cervical changes in uterine contractions. Because of the essential roles of these hormones, patients with pituitary adenomas are usually followed and treated by a healthcare provider who specializes in managing patients with endocrine disorders. And this is both pre-op and post-op. So a really nice table is on page 984. It's table 41.1. And again, that just shows like the whole cascade. So we're going to talk about hypopituitarism. So this is hyposecretion of hormones from the anterior pituitary gland. So because hormones released from the anterior pituitary regulate hormones released from the adrenal cortex, the thyroid gland, gonads, there can be alterations in all of these body functions, okay? So the hyposecretion of growth hormone is huge with hypopituitarism. Um, Deficiency of one of the anterior pituitary hormones is going to result in changes in metabolic, maybe even sexual function, depending on which hormone is being affected, right? And I mean, that just makes sense. That's why looking at the table that has the cascade of hormones, if you look at which hormone is going to be we're not going to have enough of, that's going to tell you exactly what's going to be affected, because what does that hormone affect? What does it do in the body? That's going to be your sign or symptom, right? Um, so like too little growth hormone, your little kid is not going to be growing up to par, right? You know how they do like the growth scale on little kids, like your 98th percentile with height and weight, whatever. That's where you're going to see that the kid is not producing enough growth hormone. Or the opposite, where they have too much growth hormone and they end up with acromegaly and end up with these huge overgrown features, right? So just keep that in mind. I would super recommend drawing yourself like a little table when you're looking and talking about these things, because I feel like it really helps to visualize what hormones we're talking about here. Um, Sorry. So clinical manifestations of hypopituitarism, this is going to be weakness, fatigue, weight loss, decreased appetite. They have sensitivity to cold, kind of swollen facial features or body. Specific clinical presentations of hypopituitarism are, again, going to be related to the hormone involved, right? What is actually going on? So diagnostic evaluation is gonna focus on the hormone. So the target cells, the glands, okay, maybe lack of the tropic hormone. Remember, the tropic hormones are the ones that have to do with reproduction. So we also have hormonal studies that we can do, looking at like hypo or ACTH stimulation. Then they're going to measure TSH, FASH. I don't know why I have such a hard problem with that, and LH. Also prolactin and your growth hormone, right? Um, if a tumor of the brain or pituitary gland is suspected, CT, MRI, any of those sorts of things, serum testing, all the hormone stuff, looking at all of that. Again, we're going to be trying to rule out other causes. Okay, that's just a go-to with all of this. Direct measurement of growth hormone is difficult because the levels change throughout the course of a day. So, they may do like trending with those blood tests. So medical management of hypopituitarism are aimed at restoring the target hormone levels to normal, and that's going to be true for all of these. We just want those hormones to be back to homeostasis, because then the body's going to be able to function normally, right? So this may, if we are talking hypo, which we are right now, we're going to talk about hormone replacement. And then there's stuff like supportive therapies with fluids, electrolytes, that sort of thing. Um, Hormone replacements could be corticosteroids, thyroid hormones, hypopituitarism, and hypothyroidism. Hypothyroidism in particular is very common, and we replace that with synthroid, right? Thyroid hormone. We can also replace the tropic hormones, so testosterone, estrogen, maybe even progesterone. Management of a decrease in growth hormones in adults is usually focused on the pathophysiological processes associated with those. So, like bone density, osteoporosis, that sort of thing. Making sure that the person has enough calcium and also vitamin D, because remember, we can't use, our body won't be able to use our calcium if we don't have enough vitamin D. So complications related to hypopituitarism, this can be life-threatening, right? You can develop life-threatening emergencies, particularly with pan-hypopituitarism. That, and again, that means that all the hormones are low, all of them. So lack of ACTH can result in a decrease in glucocorticoids and mineral corticoids. And this is bad because the patient is unable to maintain adequate fluid volume, which then can lead to circulatory collapse, stuff like that. Obviously, that's bad. A lack of TSH can lead to a decrease in thyroid hormone secretion, and that can result in a severe decrease in metabolism that affects all body functions, right? And this can be really important related to metabolism of medications. Okay. Women receiving hormone replacement therapy, we call that HRT with estrogen, are at increased risk for hypertension and DVTs. And this is increased if they use any form of nicotine. So if they smoke, maybe they use patches, maybe they use, what are those little things that you stick in your mouth? Those are pouches, right? So that very much has NCLEX written all over it, right? So estrogen right now is still associated with increased risk of hypertension, DVT, and this is exacerbated with use of nicotine. Nursing considerations with related to hypopituitarism, vitals, right? Hypotension and then consequently tachycardia, right? Compensatory mechanism related to that. These are related to a decrease in secretion of ACTH, which then leads to a decrease in secretion of glucocorticoids and mineral corticoids, resulting in sodium and water loss. Okay. Serum glucose levels, hypoglycemia might be present. Our person may have changes in fertility. This can be related to testosterone. So the decrease in testosterone in males could actually lead to sterility, which, so we are talking about a long-term life-altering effect there, right? In women, decreased LH or FSH can lead to amenorrhea or also infertility. And then we worry about bone density. So, that's our osteoporosis and all of that with a lack of growth hormone. Actions that we're going to do, we're going to think safety measures, especially if we're worried about that osteoporosis. So risk of injury, with a risk of pathological fractures. We want our person to increase vitamin D and calcium. Okay. Hormone replacement. All of these hormones we can replace. Don't forget when we are talking about replacement, as usual, like even when we just talked about like fluids and electrolytes, anytime we are replacing related to a hypo situation, we always run the risk of tipping our person to a hyper situation. And then you're going to be assessing for the signs and symptoms related to that hyper. Okay. So while we're fixing the hypo, always be aware of the consequence of potential hyper. With our hypopituitarism, it would not be uncommon to kind of go with physical therapy, kind of help with mobility, that sort of thing, especially related to that osteoporosis risk. Diet and nutrition is really important. We're talking calcium and vitamin D. So on top of supplements, it would be great for our person to get all of that through food. Teaching is going to be teaching about like Addison's crisis, right? Because Addison's crisis is a life-threatening medical emergency that occurs when the adrenals do not produce enough cortisone and aldosterone hormones. So, that's a big deal. So we need our people to know what that looks like, right? We'd also need them to know what the hyper aspect looks like. What would those signs and symptoms be so that they can let their physician know? Um, it's important to take hormone supplements in the morning. Taking hormone supplements in the morning mimics normal release of these hormones. And that's another thing when we are replacing hormones. We want the body to think it is a natural process because that's going to give us the best outcome. So taking the hormones in the morning, that's, one of the things we talk about. Evaluating outcomes, um, back to normal functioning, right? We want hormone levels to be normal. We want functioning to be normal. We want those signs and symptoms to have resolved because hormones are back to normal, okay? And when we reach homeostasis with supplementation for hypopituitarism, our person should be able to go back to normal. Okay, that would be an expected outcome. Now with hyperpituitarism, this is slide 8. Really take a look at this slide because this shows what excess growth hormone can do. So hyperpituitary disorders are related to hyper secretion of hormones from the anterior pituitary. As with hypo, the pathophysiology and clinical presentation are directly related to which hormone levels are elevated secondary to the hypersecretion. So which hormones do we have too much of? And that's going to determine the signs and symptoms that we see. So hyperpituitarism secondary to hypersecretion of hormones leads to specific dysfunction related to the hormone involved. An excess of one of the anterior pituitary hormones results in changes in metabolic or sexual function that depend on which hormone, right? Which makes sense. So signs and symptoms. So one of the ones is acromegaly, okay? And that is excess growth hormone. Um, this can also be related to excessive secretion of ACTH and TSH. So this is table 41.3 that kind of shows that cascade. Um, Excess secretions of LH or FSH are not associated with acromegaly physiological changes. Okay, so diagnostics, there we go. Diagnostic evaluation of hyperpituitarism is going to focus on the hormone and the target cells, and the gland, right? So which one is being excreted um, hyper too much, and what do we need to do to slow that down? Okay, so they're going to do hormonal studies. They're going to look at all the glands, all the hormones to see which one is hyper secreting. Okay, of course, may use a CT or an MRI, serum studies, all of the stuff that we keep talking about. So the goals of medical management of hyperpituitarism are aimed at decreasing the secretion involved, okay? Um, and that is sometimes that can lead to having to remove the gland. Like if you remember in hyperparathyroidism, sometimes they end up removing that gland. Okay. And then you have to think, well, what hormone did that secrete and what would that affect? And now, if I don't have that gland anymore, what part of the cascade is missing? Right? And what do we have to do to make sure that that is replaced for normal functioning. There we go. All right. So slide 9 talks about acromegaly. This is just some of the growth changes that you see related to acromegaly. Surgical management of a pituitary tumor. So hypersecreting tumors of the pituitary gland, like I was just talking about, can be surgically removed. One of the things, now keep in mind where these are located, right? So they are removed by transsphenoidal hypophysectomy. What they do is go up through the soft palate, kind of up through the nose, the nasal cavity, to get into the brain area, basically, and get to the tumors, maybe if they have to. Okay, so that is how they take out a pituitary tumor. They go through the top lip to the nasal cavity, floor of the nose, through the septum, and up through to get to the pituitary gland. So this is how we can remove some things. This is how we can get to tumors and remove tumors if somebody has something going on. So afterwards, they use a graft, okay? And the graft is going to aid in healing and presents a CSF leak. Your book says CSF rhinorrhea. Remember, rhinorrhea is just a runny nose. So CFS leaking from the nose, okay? They may also use a nasal packing in the incision, and that's just going to help that area close up and seal, basically, and not leak. And then we're going to use a loose dressing below the nares. They call it a mustache dressing. So that's great. So post-op management, though, is pretty similar for patients who go into any other intracranial surgery for any other types of brain tumors. Post-op, these patients, they need to be monitored for increased intracranial pressure, development of diabetes insipidus, meningitis. Meningitis can be related to inflammation and or infection of the meninges. And of course, we're always worried about a CSF leak. So the patient is instructed to avoid activities that could increase that pressure at the incision site. This can be coughing, sneezing, bending over, but also remember, like, straining when you poop, sexual intercourse, all of that sort of stuff as well, okay? Smaller pituitary tumors can be removed via an endoscopic approach, which poses fewer post-op complications than the sublabial transseptal approach, which is what we just talked about, going through the roof of the mouth, through the nose and all that. This procedure gains access to the pituitary tumor through a fiber optic device inserted through an incision in the lining of the nose. So that's just our good old-fashioned scope, okay? Goes through the nose. There's also the option of stereotactic radiosurgery. This is considered minimally invasive. This is if there is residual or recurrent pituitary tumors after a resection. So this actually delivers high dose radiation to a very, very targeted area of the brain. And the goal is to eradicate that tumor, right? With minimal effect to any surrounding brain tissue. So it's very, very focused, which is good. Let's see if there's anything in here. Patient usually discharged same day. The biggest thing related to this is they may have a head frame in place afterwards with pin sites. So they use a head frame during, scratch all of that. They may use a head frame during the procedure. Okay, and this head frame uses pin sites. So when the person discharges home, the head frame is going to be, they won't have the head frame, but we worry about bleeding, drainage, whatever related to those pin sites, okay? And that infection would be a concern. If they have a headache, shocker, you've had a head frame with pin sites in place. You may have a headache. You just use good old-fashioned Tylenol for that. Nursing interventions for a patient after the transsphenoidal hypophysectomy. Assessments, obviously, we're going to do vitals. We worry about hypotension and tachycardia. This could be seen with post-op DI, diabetes insipidus. Remember, that's dry inside because the body is just peeing, peeing, peeing. We also worry about temp elevation. Okay, this can be secondary to a CSF leak. Now we've gone and poked around up in the brain, right? So we worry about neurostatus. I worry about signs related to intracranial pressure. Okay, consciousness, pupil changes, remember all those neuro sort of things. Visual change can also develop secondary to post-op cerebral edema. So maybe they're losing peripheral, right? Maybe they're losing central, right? Who knows? Wherever that inflammation is taking place. So we're going to be monitoring I's and O's. This can be related to ADH. This can be related to the development of DI. I's and O's are important. Mucous membranes and mouth, we're going to monitor. We're worried about that nasal packing, okay? It can lead to dryness. We also worry about breakdown of mucous membranes that can lead to infection. We worry about urine-specific gravity. This can indicate dehydration, right? Related to that lack of ADH. Serum sodium and osmolality, again, ADH, right? Actions, humidified oxygen, kind of help out those mucous membranes. Let's see. IV access, if we are worried about the potential for dehydration, we want to be able to get fluids into our person as quickly as needed. If we're not running continuous fluids already. If we are worried about DI, our person is going to have desmopressin or vasopressin. Okay, so those are synthetic ADHs that are going to help cause water reabsorption in the kidneys. We want to maintain that head of bed 45 to 60 degrees. We don't want to do anything that is going to increase risk of ICP. It also helps with breathing. It helps with just the drainage related to fluid going through the jugulars, okay? So just like letting gravity be our friend. We want to help our person and encourage our person to drink fluids if they are able, mouth care if there's anything going on there, teaching signs and symptoms of meningitis. Okay, that it does put our person at risk. Remember, our things with meningitis are that nuchal rigidity, that stiff neck, photophobia, maybe elevated temp. Signs and symptoms of DI. We want them to make sure that they are not having increased output, or excessive thirst. It's almost like it's pretty similar, really, to your signs and symptoms of diabetes type 1 because you have that increased urine output, which leads to the excessive thirst. So, any sign, we also want them to pay attention to signs and symptoms of fluid overload. Okay, so that's the weight gain, the daily weights, the edema, all of that stuff that we've all learned about. So we are going to be doing all of that education. Overcorrection of DI with either vasopressin or desmopressin can lead to fluid overload. So again, we have a hypo situation, we treat it, we overtreat it, and now we have a hyper situation, okay? We want our person to use a soft toothbrush after a transsphenoidal hypophysectomy. That's just because there's going to be an incision line in there and we don't want to damage it. Try to avoid coughing, sneezing, bending at the waist, all of that. That stuff can put strain on the surgical site. We also worry about increase of ICP. We want to know about increased drainage from the nose related to CSF. CSF leak can also increase risk of meningitis because if CSF is leaking, that means there's a hole somewhere. And if there is a hole somewhere, that means organisms can get on up into what should be a closed system. So that puts us at risk for meningitis. RN management related to hyperpituitarism now. This is slide 12. So we may see hypertension, okay? This can be secondary related to excess secretion of mineral corticoids. Um, don't forget that's going to lead to reabsorption of sodium in water, which would be a hypervolemic situation, which of course increases our blood pressure. We can see neuro changes with this as well, vision changes. Pituitary tumors can cause an increase in intracranial pressure. As those tumors enlarge, they can press on on the cranial nerves, right? So we worry about that. This is where you get into finally in real life assessing those cranial nerves. Because if we have a tumor pressing on them, you're going to see that dysfunction. Again, we're going to do I's and O's. Um, Output can decrease, okay, because we have reabsorption of sodium and water. Um, or you may have excess output related to DI. This is daily weights again, okay? Serum electrolytes. Now, because this is the hyperpituitarism and we're worried about increased growth hormone, this is where we're going to monitor for those change in size of hands, feet, bone structure, right? Is the face starting to look abnormally shaped? Um, with increased growth hormone, this is sort of weird. You can actually get thickening of the bones themselves, which you might think would be a good thing, except that we are set up to carry our bones at the size they are supposed to be, normal size, right? And so thickening of the bones can lead to increased weight of the bones, which then is hard on the whole body to have to pull around that extra structure. Okay. Neurovascular status. In patients with acromegaly, bone growth may compress the peripheral nerves. And this can cause numbness, tingling, pain in hands and feet. So, more of the suppression of that nervous system. Um, Administration, we may give dopamine agonist, which is going to inhibit the release of the anterior pituitary hormones. We may give somatostatin analogs, which inhibits release of growth hormones. And then we may give hormone supplements. So this could be like replacing sexual hormones, whatever, just to facilitate normal functioning. Teaching is going to be related to disease process. And again, you want to know side effects on both sides, hypo versus hyper. And then, of course, we may actually collaborate with our pharmacist related to medication teaching, because there's going to be a lot of meds related to this. And, your pharmacist is really good at knowing potential interactions, what to think about with this, and all those things. So this is something where our pharmacist really, really could come in handy.